Good morning, Chair Schrag. We do have quorum. I am not sure if Commissioner Apario is on his phone, but we do have quorum at this time. Oh, I'm sorry, you're on mute.
I just realized that. Started talking. Fantastic. Good. So we're set with quorum. If you could just do a roll call for our for the record so we can get started, that would be great.
Yes, this is Katie Martin Waldman with DCFS Professional Support to the DCFS Commission on Behavioral Health. We'll start with roll call with Chair Schrag.
Present.
Commissioner Ruiz Lee.
Present.
Commissioner Durette.
Present.
Commissioner Giron.
Giron.
Giron, I'm sorry.
That's okay, Kate. Yes, here.
Commissioner Ficalora.
Present. Good morning.
And Commissioner Apario. And Chair Schrag, as I have been in contact with Commissioner Apario, I believe he is still planning on joining us this morning. But even without his attendance at this moment, we still have our quorum for this meeting.
Fantastic. All right. Well, let's get started. We have been. We'll call this meeting to order. Welcome everybody to the commission meeting today, and welcome to 2023. I'm really excited for this new year and where we can work together, continue working together as a commission and our various boards and agencies and everyone's involved. And so I just want to kind of, as we closed out 2022, I just want to start here in 2023 with that reminder of, really taking a collaborative approach to what we do, really working across the various activities, responsibilities, ranks, roles, everything that we have to ensure that we're leveraging the resources that we have to the best and fullest extent that is possible to positively impact our youth, our adults, and those that are needing this, behavioral health support across the spectrum. So just as a reminder, that's kind of my continuing focus and goal. I know that's shared by the rest of the commissioners. And with that being said, let's get started with agenda item number 2 today. This is going to be a public comment and discussion. No action may be taken on the matter raised under this item of the agenda until the matter itself has been specifically included on an agenda item upon which the action can be taken. And as a reminder, all public comments are limited to 2 minutes. And when you are making your public comment, please state your name. And if you represent an organization, to please do that so we can make sure that it's accurately reflected in the notes for later. Do we have any public comment at this time? All right. Well, seeing and hearing none then, we will move on to, just one moment, I'm having a little computer glitch here. All right. Seeing and hearing none, we'll move on to...
Hang on, Commissioner Schrag. Dr. Haboush-Deloye raised her hand.
Oh, okay. Sorry, I didn't see that.
Hi,
Go
this
ahead.
is Amanda Haboush-Deloye for the record. Sorry, I was a late raiser.
Oh.
I just wanted to mention that we will be hosting, the Nevada Institute for Children will be helping to host Children's Week at the legislature, which will be March 13th through the 16th, that Monday through Thursday. Tuesday is actually dedicated to children's mental health. And we do have a bus that will be going up from Las Vegas to carry families who would like to join from Las Vegas up to Carson City on Sunday, coming back on Monday. And the Children's Advocacy Alliance has actually offered to send another bus up if we have enough families that are interested. So we also talked about seeing if we could get another bus, like another day of the week, to have a presence all throughout the week. I can drop the website in the chat that has links to register. All kinds of families have taken the bus, so we've had them come up with, you know, babies on the bus if they're comfortable with, you know, bringing all their family. It's free. We get hotels donated, and we have some funds for that, and it's all the foods included. We have breakfast and lunch every day for all participants, and then we'll have a schedule out soon. So we hope that people are able to join, and if you have anything specific that you would like to help or to plan for that day, we would love to have participation. Thank you.
That's fantastic. Wonderful. Do we have any additional public comments? All right. Seeing and hearing none, we'll close out agenda item number 2. Agenda item number 3 for possible action, approval of the October 10th, 2022 special meeting minutes. Commissioners, I know we all had an opportunity, for those of us that were present at that special meeting, and then had an opportunity to review. Is there anybody who has any comment on those from the commission side? Is there anything that anyone has a comment on?
Commissioner Ficalora, for the record. It says that I was present and I wasn't. I wish I was after reading the minutes and seeing everything that came out of that, but I wasn't there. So,
Okay.
Commissioner Durette, for the record, same.
Yeah. All right. On that, Carrie or Katie, can we have their name moved to not present? Okay. And would anyone like to make a motion that with the names for approval, with the name under the expectation that the names are moved, or do we need to place them for a different day? I believe we can just have their names moved in the public comment or in this setting, and then approve them as such.
This is Jennifer Spencer with the AG's office. Yes, you can with those
Okay.
corrections.
Perfect. Then would anybody like to make a motion having those names moved and approving the rest of the minutes as presented?
So Commissioner Durette, I would make a motion to approve the minutes minus our 2 names.
All right.
Commissioner Giron, I'll second that.
All right. All in favor? Say aye.
Aye.
Any nays? Any abstentions? All right, so be it. The item agenda has been approved as discussed here today, and we'll move on to agenda item number 4. This is for possible action and update on the recent concerns regarding seclusion and restraint reports from Never Give Up. Daniel Cox, who will be, I believe there was a slight change in everything. Mr. Levin, I believe you are going to be presenting today.
Yes. There's actually been a restructure of the organization, effective as of January 1st. It's been a long time in coming. When we first entered the state, over a year ago, we realized we needed to make some, big changes, for Nevada's system of care, and, to ensure that we're giving the highest quality and best outcomes for these kids. So, as of the new year, or even before that, we've been working through many changes in the organization. So today on this call with me, I have our new leadership team, including Becky Homer. I'll let her introduce herself, and Michael Spindler and Kyle Dunlap. That is the management reorganization. We'll get into that a little bit. This when we look to increase quality and make big changes, sometimes we have to make really tough decisions. And that's part of what we did as an organization, introducing new clinical people, introducing more enhanced, clinical sessions, and overall organizational structure and the culture of the organization. Specifically, I had a meeting with all of my staff, in the beginning of the year, and we sat down. We said, "What are our goals for the year?" And every single goal was focused on specific quality metrics that we want for this organization. And it's not just, the vision that we have, which obviously is high quality outcomes and reintegration with the families, for our kids, but it's actual work that's been done since our last meeting. And that's what we're here to report on today, is what those changes have been and how we've been able to really move the needle in all of the areas that we've focused on, which is very encouraging to me. I myself, I'm in Nevada every single week for the last quarter, and plan to be there to see everything through. One of the things that I do is I attend a meeting with our parents, where they can come and voice concerns directly to me, and the clinicians involved. And that part of that has been really, really helpful, not just in listening to the parents, but also encouraging our parents to, go through the treatment that they need, or coordinate with their kids a proper reintegration plan and a proper discharge plan. And we've seen so much success in that. And we've got the numbers, better than stories, and what we've, how we've been able to touch families is the actual numbers, which we will get into. Another area where I'm very proud of is our new discharge, our discharge and outcomes coordinator has made such strides, even with kids that were from rural areas in rural Reno, Nevada, outside of that area, where we've gone back and forth 8 or 9 times with different possible treatment options, system of care issues. And we've been told, no, there's no services, there's nobody that can help. And we say, that's not an answer. We need to do something more. We need to ensure the outcomes are good. And we've found discharge opportunities for every single one of our kids. And are, working to increase. We understand it's not just, we can't just live on our island. We're all part of one bigger, larger system. And if the issue is transportation, I say, let's find the resources to get that transportation for that kid to be able to go to the outpatient and not have to be rehospitalized. Yesterday, I met with some of our community partners in the Las Vegas area, some of the acute care hospitals, and discussing the fact that, how important it is to properly step down kids from acute in a way that's strong and lasting. And that's been our focus. That's always been our focus. And we have some great data to show to that today. Ultimately, I look at everything now the way in 90-day increments, similar to how often we're reporting to you. So you'll be very encouraged by today's data, but let me tell you something. There's a lot more that's going to happen in the next 90 days, even more than you'll hear today, which is a big commitment. It's a big commitment financially for us. Over $1.5 million was put into the capital improvements, into the structural improvements, safety, but even more than that, we've invested, and you'll hear today, a tremendous amount into our training and our employees and the quality that's coming out. and it's paying dividends. I have to say, when you focus on quality and you make it a priority, we've met with tremendous success. You'll hear about the data today, and you'll see some new faces. But I'm telling you that besides for that, it's the vision that where we're heading. It's not just what we've done until now, it's where we're going to be going from here. So if it's a reduction in holds, reduction in time of holds, reintegration with family success, all of those are numbers that, even though we've improved upon, we're going to be doing so much more. And that's a commitment from our company, from me, myself. And, you know, now that we've been here over a year, and now two government administrations, we are going to be here for the long run. We're not here a fly-by-night operation. We're here to solve the crisis. You know, when we first started, I first came in, obviously, I said, this is the 51st state. Let's start here because they could use some help. And, you know, we didn't know how tough it would be, but I didn't know also how great the people that I'd be working with are. All local people, Becky, Kyle, Michael Spindler, the various clinicians that work for us, Dr. Lisa, and the therapists who, down to even the care coordinators at Medicaid that we work together with. Everybody here is invested in Nevada. They're here because they want to see Nevada succeed. And I believe that with that type of determination and that energy that's there, that's what's really propelling us. So although the challenges have been, you know, very, very tough, and, you know, working in a system, obviously, that has a lot to, still has a long way to go. It's the coordination and working together with the community partners that's the most inspiring to me. It's the fact that when we got told from one of our clients that we're discharging, no, we won't be able to find placement for them in a rural area, and we were able to coordinate with various different parties that were so interested in just helping this kid, you know, being, you know, patient-centered, that we were able to succeed in that area. And having those reintegration and being able to step down appropriately, that is one of the biggest components to success and helping the kids. And I have no doubt, you know, after you'll hear it today, you'll see the direction of the company. You'll see the direction of mental health in Nevada, because honestly, we are the largest facility, the only facility that takes a lot of these kids that otherwise would be, you know, sent out of state. Reintegration with the families would be that much more difficult. And, you know, now that the quality has taken such a huge, drastic step, you know, in the right direction, I think it's encouraging for us. And, you know, I will be reaching out to, you know, to you community partners, as I am with many, to coordinate a lot of this, you know, a lot of the challenges that we're going to see and we're going to work through, whether it's, you know, finding a way to transport these kids to IOPs and outpatients and making sure that happens, or you know, navigating the different challenges that can come up. But I do know that with the collaboration that Commissioner Schrag talks about, and I know that's, you know, in the heart of the whole commission, I know that we will succeed here. We are comprised of Nevadans who care for their community and know that the system of care needs this, and we are committed to being that answer for the community. And so I would like to hand it off now to Becky Homer, my, I would say, new Vice President of Client Services, who has been in the market for many years, and more importantly, is on site together with me 5 days a week or more, to see that change, not just to plan it, but to actually see the training that was planned, the investment that was planned actualize in real time on campus.
Thank you, David. I appreciate this opportunity to participate in such an important meeting. I'd like to start by introducing myself. I've worked for Never Give Up for about 5 months. I was hired in August of 2022 as the Vice President of Client Services. Regarding my professional background, I have a master's degree in mental health counseling and am a certified substance abuse counselor. I've lived in Nevada since 2006, and I've held leadership positions at Monte Vista Hospital, Desert Hope, and Desert Parkway. Before I get into all the numbers and things, I just want to pass it off to Michael Spindler briefly to provide an update on our sanctuary training initiative.
Thank you, Becky. At our last commission meeting in October, I had indicated that we were in the process of conducting a sanctuary leadership training over the course of last summer. That training concluded in September, and at that point in time, we began to implement the sanctuary model on our campus. Over the course of this past November, we conducted 16 sanctuary trainings off-site with 128 staff in attendance over this period. We are delighted to report to the Commission that more than 90% of all staff at Never Give Up are currently fully trained in the sanctuary model of care. The sanctuary training that was conducted was recorded. It is now posted on the Never Give Up training platform and is being used to train both new hires and used as a refresher for current staff. Becky, our Vice President for Client Services, will be able to walk the Commission and the participants in this meeting in articulating exactly what's been implemented thus far relative to the sanctuary model and some of the early outcomes that we have begun to realize. So, Becky.
Thanks. So since our last meeting, specifically with Sanctuary, community meetings with staff and youth are taking place twice each day. Leadership and staff have begun to use sanctuary language throughout the campus. An implementation of the sanctuary model is continually being monitored by administrative staff. Employees have embraced the opportunity to shift the culture to a more democratic model that embraces nonviolence, social responsibility, and commitment to growth and change. We're beginning to see positive outcomes. Physical holds have decreased in number and duration. Communication amongst staff regarding children admitted to the program has dramatically improved. Staff are now provided with a brief clinical summary on each child, which includes their clinical history, triggers, coping skill capacity, and safety plan. Red flag meetings are now taking place on a regular basis and can be requested by any staff member. As you have been told, the full implementation of the sanctuary model can take anywhere from 8 to 12 months to become fully integrated into the program, and staff have responded positively to greater transparency, communication, and our commitment to creating a safe community where all staff and client voices are heard. And we're beginning to see outcomes we had hoped for in our data. So specifically talking about safety holds, the safety holds or restraints information is that when Sanctuary began to be implemented in October, November, and December of 2022, we compared those numbers to the preceding 3 months, July, August, and September of 2022. We realized a 53% decrease in the use of our physical restraints. The duration of physical holds continue to decrease month over month. In October of 2022, the average duration of a physical hold was 8 minutes. In November of 2022, the duration of a physical hold was 7 minutes and 50 seconds. And in December, the average duration of physical hold was 7 minutes. So this represents a total decrease from October to December of 13%. We've achieved these improvements and outcomes in part and as a result of increased CPI training and the use of de-escalation techniques. All physical restraints are now followed by a documented debriefing session, and debriefings are reviewed by clinical staff daily, and clients are provided with the opportunity to discuss the physical hold, why the hold was necessary, and triggers that led to emotional dysregulation. After I was reviewing the notes, the minutes from the previous meeting, I tried to capture and answer and address as many of the things that were brought up as possible. And so I identified that the program priorities from that meeting, and I'm going to kind of go through those specifically one by one. So the first one, leadership. Structural and organizational changes have been initiated. I've been hired VP of Client Services. I am on campus 4 to 5 days per week and overseeing daily operations. We also now have a physical plant coordinator who is on campus 4 to 5 days a week as well, overseeing the physical facility daily and attending to physical plant needs in real time. In regards to staffing, we've initiated a more robust interview process for all applicants that include an initial screening with the Human Resource Department, followed by multiple interviews with program staff, including residential, clinical, and medical leadership. We've addressed the onboarding to include 32 hours of training before staff begin their work with children. And topics covered include cultural competency, the sanctuary model training, and crisis prevention. For us, crisis prevention training is conducted every 6 months or more for those staff in need of additional training. We currently have 2 certified trainers on staff, and I can say that we have 98% of our employees fully trained in CPI and de-escalation techniques. Client rights and responsibilities, de-escalation training, which includes the use of our safety plans. New hires are expected to shadow experienced staff for 40 hours before assuming responsibilities. We also utilize in-the-moment supervisory intervention, and it's provided by leadership when appropriate. We continue adjusting and modifying staff schedules in the service of optimizing staff engagement and mitigating burnout. In terms of programming, we have broadened the admissions process to not only include the Chief Admissions Officer and Clinical Lead, but also the VP of Client Services, Chief Clinical Coordinator, as well as the Academic Director. In an effort to enhance the transition of new clients into our program and ensure youth have an understanding of all elements of Never Give Up, we've developed a more easy to read client handbook. Each new admission is provided with the handbook, which they read together with staff. Clients are given an opportunity to have their questions and/or concerns addressed. Clients are also informed of their rights upon admission and when appropriate thereafter. In terms of crisis intervention, previously we noted the observation unit on campus, but we've now transitioned that to call it the sanctuary unit. It's designed to support youth in achieving emotional regulation and enable them to return to programming as quickly as possible. Youth may request admission to the sanctuary unit if it is included as a safety plan option. All clients, with the support of clinical staff, develop a safety plan which identifies alternate ways to de-escalate during stressful situations. The sanctuary unit is frequently included as an option in many of our kids' safety plans. We view the sanctuary unit as a short-term coping mechanism for our kids. The sanctuary unit provides them with the opportunity to self-regulate with the help of staff. It's not punitive, but rather a support for our clients in crisis. We've begun collecting data on the number of admissions to the sanctuary unit and length of stay. We've also created a new electronic thread and we have instituted that for all staff that provides, as mentioned before, the clinical summary, the history of the child, safety plans, and even if there's a self-harm protocol, if needed. And then also it lists each child's coping skills and triggers. This thread enables all staff to quickly and efficiently obtain pertinent information relative to each kid in care, and it individualizes the interventions that they may need. We continue to be challenged, though, with recruitment of medical professionals in the program. We've implemented the regular and ongoing use of our advanced practice registered nurse for consultation in an effort to determine whether off-campus medical intervention is necessary. With our documentation, we have retained a clinical auditor to assist with maintaining adequate and comprehensive treatment plans, the CASI-2 worksheets, as well as the updating of master treatment plans. Additional training is being provided for direct care staff regarding correct documentation of critical incidents. Critical incident reports are monitored for completeness daily. We've also implemented a protocol in which critical incidents are reported to parents within 24 hours of the incident by a member of the clinical department. This protocol includes an electronic notification that goes to the clinical team. The team member then notifies parents, explains what happens, and once the parent is notified, the exchange is documented in the child's record. Once the reports have been completed, the staff acknowledge completeness on our electronic thread, and this protocol is supervised by the chief clinical coordinator. Specifically addressing our facility, a physical plant coordinator has been hired, and they interface with staff and leadership daily. The physical plant coordinator walks the facility daily and initiates repairs as necessary. In addition, staff leadership, including the CEO, myself, VP of Client Services, residential administrator, also conduct daily inspection of the facility. So we continue to review, assess, and initiate facility modifications to make the living quarters as comfortable and home-like as possible for our kids. We've made a concerted effort to enhance communication with parents. Parents are now invited and requested to attend their child's treatment team meetings along with their child. As David mentioned, we've initiated our bi-weekly parent support group. All of our parents are invited to attend, and the group is chaired by a member of our clinical staff. Parents also have the option of joining virtually in an effort to engage as many parents as possible. Our CEO, David Levin, participates regularly, as he said, along with other members of our leadership group. We've also initiated the planning and service review meeting. These meetings are designed to address and provide an opportunity to modify treatment plans for those clients who manifest repetitive and maladaptive behaviors or are involved in continual untoward events. Additionally, planning and service review provides an opportunity which is independent of scheduled treatment team conferences and red flag meetings to address those clients who have reached a plateau in their treatment. Planning and service review meetings have also been initiated at the 9-month point to determine whether continued care is appropriate based on clinical evidence. Discharge planning is discussed at the time of referral, through the admission process, and regularly with parents during the course of treatment. The discharge planner works closely with the family to ensure a smooth transition back home and to a step-down level of care. So our average length of stay in July, August, and September of 2022 was 326 days. However, our average length of stay November, December, and October, November, and December of 2022 was 277 days, which puts us at about the 9-month mark. Now, we recognize that we've had some kids in our care for longer than we'd like, and it can be attributed to many variables, including and mostly due to an unsafe environment to discharge to. So, in order to mitigate that, we started working on the discharge plan of each child prior to admission and throughout the time in care to help establish a smooth transition home. utilizing our planning and service review meetings, our red flag meetings, and a more intensified collaboration effort with parents during those regularly scheduled treatment team meetings has shown to be effective in decreasing our average length of stay by 15%. We've also, with programming and collaboration with our youth, a youth advisory board has been established. And what that looks like is that each unit of children has selected a representative from their unit who meets bi-weekly as a group and also with leadership to address concerns and or any programmatic issues. Developing a youth voice is a core concept in the sanctuary model, and it creates opportunities for clients to begin to make their own decisions and exercise autonomy and control over their life. So now I want to go into just the plan for our next 90 days. And as David said, the list is far longer than what I'm going to be presenting on today, but I hope this gives you a good idea of the direction that we're heading. Leadership will continue to monitor new initiatives regarding the amount of time children spend in the sanctuary unit, with the intention to have children spend a therapeutic amount of time in the unit to regulate their emotions and discuss a plan for reintegrating to their unit. Leadership will closely monitor the integration of the sanctuary model of care throughout the program. Leadership will continue to work toward a greater reduction in restraints and their duration. Leadership will also continue to work toward 100% of all youth being assessed by medical staff immediately after a critical incident. We're collecting data on the use of our sanctuary unit, and we hope to see a reduction in its use with ever shorter stays. We hope to improve communication across our program and interdepartmentally through monthly general staff meetings. Our physical plant will continue to be closely monitored with an eye on expeditiously addressing repairs and creating as comfortable a living environment for our children as possible. New ways of engaging and enhancing communication with parents will continue, and our organizational structure will continue to be evaluated and modified as necessary. We're confident through the changes already made and our commitment to enhance services to children that we at Never Give Up will continue to evolve and build upon successes already achieved. And we will continue to prove that we can move this program forward with the best interest of our kids in Nevada. And that's all I have. Thank you so much for my part.
Thank you, Becky. And Mike, would you like to add a few words?
Again, I think Becky's presentation was pretty comprehensive. We realize the challenges that we have ahead of us. We have realized over the last 90 days some significant movement in the areas that the Commission and other stakeholders have identified as concerns. We share those concerns, and we are really quite committed to continue the process of improving services, dramatically reducing and perhaps eventually eliminating physical restraints, dramatically reducing the use of seclusion, a more comprehensive and complete integration of the sanctuary model, better documentation. As I said, we have begun to see the numbers heading in a direction we want to see, and we are working at full speed to continue to see these changes and really, as Becky said, grow and capitalize on the changes that have already been instituted.
David, I appreciate you and your team this morning sharing some updates with us. Obviously, it's, there were a lot of issues and concerns that we had, and that's why we've identified this as such a big topic. Anytime we have significant seclusion, restraint, data that suggests a pretty significant concern. I was reviewing some of the details, in the minutes and looking over some of the past seclusion and restraint data from, some of the reports that we look at. And, when you look at it, 40, 50 minutes for holds, obviously we want to get those numbers down to, I believe the national average is, and Dr. Durette, please correct me, around a minute or less. Is that, I believe that's the national data, correct?
That would be correct. And may I ask a question, or did you want to keep going? Because I had some very specific questions about this.
Yeah, I was just going to say I'd like to. I'll kick off with one question, and just for the record, at this time, commissioners are the only ones that can ask questions of the Never Give Up staff based on this format. Questions can be posed in the chat for later under public comment, and we'll get to that section, and we can work to have those questions answered as necessary. So David, as I kind of indicated there, we have some pretty significant concerns when it comes to seclusion and restraint, and some of that comes from a culture change. And I know you're working on the sanctuary model, and changing a culture can be difficult, even if you provide some new training, a new model to follow. So I guess, what are you and your team doing to help change the culture at Never Give Up that moves it in a direction that does not, encourage long, aside from training, but, helps to encourage a better environment for staff? I heard something about, working on schedules, but what are you doing to change that culture so we collectively as a state, you as the, Epic and Never Give Up, ensure that the right culture is there to provide an environment that is best for the kids?
Absolutely. I'm gonna start with Michael, and then I'll go
Okay.
after him.
So I think that's a great question, Commissioner. I'm sorry, Chairman Schrag. The organizational restructuring that David spoke about at the beginning of the meeting, I think is one of the most significant areas that we have moved in to begin to change that culture. The culture really, in my view, begins with leadership and works its way down. Becky Homer has a particular point of view and philosophy about working with children, and a particular point of view and philosophy about mitigating the number of restraints and seclusions. She is now overseeing the campus, and some of the former folks who were in leadership positions are no longer involved in the operation. So I would suggest to you that probably is the singular most significant change. I think David mentioned it's really hard to make some of these decisions, difficult to separate the folks who've been with the organization for many years, but we needed to do that in order to implement the new vision that Epic Behavioral has created for the program. So I think that is singularly probably the most significant change that has taken place in the service of reducing seclusions and restraints. And again, relative to the duration of restraints, as Becky indicated, we have already realized about a 12% reduction in the length of time that children are involved in holds. And as Becky mentioned, in the month of December, the average hold time was 7 minutes. That is an enormous reduction from where it was. The number of holds have been reduced over the 3 months, October, November, and December, by 53%. We are not satisfied with those numbers. we view this as the beginning of an ongoing process. It would be, we believe those numbers. We are committed to bringing those numbers down. And if at some point we can eliminate physical restraints altogether, that would be a wonderful goal. There are a number of residential treatment centers in the country now that have actually moved in the direction of eliminating holds altogether. That's an aspirational goal of ours while we continue to drive those numbers down. You asked about the additional pieces that account for this. I think that one cannot overestimate the impact that the implementation of the sanctuary model has had on the program. 128 staff, and we are talking about staff at all levels of the organization, from leadership, CEOs, through clinical, through direct care, through support staff, from human resources, admissions, maintenance, sanctuary, and the model has touched every facet and every group of staff in the organization. And as you guys have heard me probably ad nauseum talk about, the sanctuary model stresses nonviolence and safety. And staff have not only bought into that model, they have embraced it and have become invested in it. So we have replaced physical holds frequently now with verbal de-escalation techniques and the implementation of safety plans. It is between the organizational restructuring and shift in leadership, the intensive training that has taken place really over the last 6 months, including a back-to-back set of 16 trainings in the month of November, off-site, which is really important, at our outpatient location. So there are no programmatic distractions, and people are asked to turn their phones off while we've done the sanctuary training with all of our staff has had an enormous impact. As Becky mentioned, we have done a enormous amount of work in therapeutic crisis intervention, de-escalation techniques, and therapeutic restraint with our staff. So we are at a point now where over 90% of our staff have been trained, again, in de-escalation and therapeutic restraint, but only when it's necessary. And as I've talked about at our last meeting, and it's centerpiece of our sanctuary training, is the notion that anytime you put your hands on a child, it is traumatizing, re-traumatizing for the child, and it's also traumatizing for the staff. Staff get it, they understand that, and we have done a full court press to do everything we can to reduce that number dramatically. And as I said, we're beginning to see the fruits of our labor, and staff understand that as well. So
I would just,
yeah, please.
I would just add to that also, you know, this commitment to making sure that before our staff hit the floor, they are fully trained, 32 hours of robust training before, and shadowing before they get in there. So they're not thrown into something and they understand, de-escalation tactics. I am 100% committed to that goal of zero, understanding that, like Michael talked about, when you come in, organizational structure, these are big, tough decisions, and they have tremendous outcomes. They have great, obviously the data is talking for itself, but this is where you're seeing the shift, right? You're seeing the shift, the 53% reduction, the 13 in holds, the 13% reduction in time. I think that accelerates a lot more in Q1 of 2023. As as these things are really taking root now, right? We're starting to see a beginning of that shift, but we're not going to be satisfied until we're not looking to be run of the mill. I know we were talking about, the average in the nation. Our goal at our annual meeting, and spending, that wasn't my goal, it was the entire team's goal, collectively, is to be the premier service, right? So until we are number one, and we're not looking to look at averages and say, hey, could we be like the average? So yeah, 1 minute holds, that's a great thing. I think the bigger goal, obviously, for us is to get to 0, and to have a residential treatment center where we're using only other de-escalation techniques. Right now we're seeing a tremendous shift, like Michael talked about, in the decrease. Things are really heading in the right direction, and again, I guess you guys can imagine what that type of investment is in that, in the staff, in those trainings, those offsite trainings. We're talking about people who are at this time at overtime, time and a half, but really that's not the concern for us. The concern for us is right now, how do we have the best clinical outcomes, and how do we have the best campus for these kids? And ultimately, we're seeing in the short time that we've made this big organizational change, we're already seeing dividends, which to me tells me, being intimately aware of what's going on a day-to-day, not just month over month, is that these numbers are going to get exponentially better in 2023.
And David, I just want to piggyback on the onboarding comment that you made. So before a staff member hits the floor, so to speak, they are receiving 32 hours worth of the crisis intervention and restraint training. They are shadowing an experienced staff member for 40 hours, and they a soup to nuts sanctuary training. So we have created a much more intense and robust onboarding regimen, which I believe has helped account for the reduction in the use of physical restraint and the reduction in seclusion. So that is a big part of it. We have been crystal clear with our staff that the only justification for a physical restraint is when every verbal de-escalation technique has been exhausted, and that child continues to represent and present a danger to himself or herself or others. And that is the only justification for a physical restraint, and only after every verbal effort at de-escalating, including the use of safety plans, have been exhausted. And
Great.
we are crystal clear about that.
Right.
And
I know that we have some other commissioners that have some questions, so I appreciate that.
Sure.
I'd like to move in. Dr. Durette, I know you had, Katie, did you have an admin?
Yes, if I could just remind everyone to please state your name and your organization before speaking. This will really help us in differentiating the speakers for our meeting minutes. Thank you.
Awesome.
Sure.
Dr. Durette?
Yes, thank you, Commissioner Durette. For the record, I hear you speak about training and having the 32 hours of training before your staff hit the floor. One thing I did not hear you mention is training in children's mental health diagnoses, and to understand the subtle nuances across diagnoses, what normal development is, and how that plays out with the intersection of normal development, because you have latency age kids, you have adolescents with a host of diagnoses. Please explain.
Well, are you speaking now about training across disciplines? Are you training for our clinical people, or training for our director, or all of them?
Any staff who have interaction with young children who have psychiatric diagnoses, I would assume would have training in normal childhood development as well as child psychopathology and the intersection of the two.
Well, our clinical staff are all master's level people with postgraduate education, so they're pretty well trained before they come to the work.
Well, I would like to pause on that one, Michael.
Sure.
Just because somebody has a master's degree, you know, I run the master's in couples and family therapy. There's not always consistent training in child and adolescent specific issues. And I'm asking very specifically about child and adolescent issues.
Okay. So, but you're asking about training relative to children and adolescents.
That's correct, because I will not assume that all your staff have that training.
No, and you're correct, by the way. You're correct. We do have weekly clinical supervision for all of our clinical staff that is conducted by our chief clinical coordinator, who has been in the field for over 25 years. Relative to our direct care staff, we have provided them, in addition to their regular supervision, with clinical summaries on each of our children, explaining what their trauma background is, what their triggers are, etc. And that is discussed with them relative to how it influences and should impact the nature of the intervention with the child. We have not at this point in time begun training relative to developmental issues in children and adolescents. We have candidly, for the last 3 months, immersed ourselves in the sanctuary training, in the crisis intervention, and therapeutic restraint training. But the kind of training you are talking about is, will be implemented going forward. We can't do everything at once, and we have to pick and choose our priorities. So for the 90 days that have taken place since our last meeting in October, the training has really emphasized the implementation of a new model of care, therapeutic, crisis intervention, and therapeutic restraint training. But the kind of developmental training that you're talking about relative to children and adolescents will take place over the subsequent 90 days.
So am I understanding correctly that you are hospitalizing youth for upwards of 90 days and none of your staff have formal training on childhood psychopathology or childhood development?
Well, again, I would argue with you that our master's staff, our clinical staff, get a 2 years worth of training in graduate school.
And I would argue that the training in graduate school does not cover child and adolescent psychopathology. We have Commissioner Ficalora, who has a master's in couples and family therapy, who could attest to that, as can other commissioners on the call.
Right, but
that's a huge concern for us as the commission.
Okay, I hear you and I understand that. I appreciate your point. Somebody going to say something?
Yeah, no, it's David Levin, for the record, CEO of Never Give Up. And we're here not just to talk today, as always, we're here to listen. As you can tell, we've taken a lot of notes from the last meeting, and not just taken notes, taken action. There are people here today that weren't on last meeting, and there are people on the last meeting that aren't here today. And the commitment that I have is to making the organizational change necessary to provide the best outcomes. And for the record, we are looking at, there are 2 separate trainings that we're looking at, one at the University of Oklahoma that we actually have on our platform, on our for residential training specific to youth and adolescents. And we're offering a extra stipend or extra rate to our direct care staff if they are able to complete that training. It's not required in the state, but that's something that we're doing because we want to, increase, like everybody here, we want to increase the quality of the outcomes and the quality of our staff. Like Michael said, there are plenty of people on our staff who have many years of experience in this specific space, working with kids, working with child and adolescent, and on hand to direct staff on a daily basis, including Becky Homer, who's here today, but plenty of our other staff who have been around, and there's more to come. I am adding more clinicians. I'm adding more robust programming, and I'm taking notes today because I see that this is an issue for you. This is something that's important to you, and I believe that if it's important to this commission, and this commission is focused on the kids, focused on how we can do better for the kids, then it should be important to us as well. And that will be a priority for us as well.
And the only thing that I would add, David, I'm sorry, this is Mike Spindler. I just want to just inject something really quick. That as part of the sanctuary training, we spend a great deal of time talking about trauma and how the relationship between trauma and psychopathology. So, I mean, there is a significant piece of that in the sanctuary model training that gets involved in an extensive dialogue about how trauma culminates in psychopathology and what that symptomology looks like and the best way for our staff to address it, when we have a situation on campus. It's not exactly what the commissioner was talking about, but I do think it's an important element in our training that really does touch on trauma and its relationship to psychopathology and diagnoses.
David, I appreciate it. I know we've got some more questions, and I'm sure you and the rest of your team can understand. There's, as a commission, we're tasked with, we have a pretty specific scope of what we cover, and we want to make sure that not just never give up, but anybody throughout the state is meeting the benchmark for kids, not just meeting the statutory requirements that are out there, but if we're looking to excel as individuals, as organizations, we're going to be paying close attention to never give up over the next year or two at minimum, because we want to see that, as we talked about, that collaborative approach. And I think as long as we work towards that accountability factor, we want to see Never Give Up successful. We want to see the kids taken care of. We want to see the programmatic activities expand, training, quality of staff, and everything else that goes along with that. So I'm sure that you and your team will understand that, we're going to have some questions. There's a pretty significant history of concern that we have, and want to make sure that that we don't slip back into a situation where now we play catch up. And I would say that goes for not just Never Give Up, but any organization throughout the state that, as we review this seclusion and restraint data and we look at the areas that the commission has purview over, we're asking those questions, and I would hope that everybody would expect that, we continue to do that, because it's the right thing to do. Yeah.
Can I just say that I'm just extremely appreciative of this commission and the time that you put into this, and including the Commissioner Durette, obviously, letting us know where your concerns are. There are people out there that have a concern and won't bring it up, with me, and that's why I'm trying as much as possible to be as visible as possible. And I am, Commissioner Durette, I am going to give you a full update in 90 days about what we're doing in that specific area. I do believe that the only way we can become number one is by listening to everything that you're saying, and not just from a statutory requirement, because if we were trying to do that, we wouldn't have changed culture over here. That's not what we're about. We're looking to really fix this system. It's taking a lot of work, but we're ready to do it the right way, and that's listening to every one of you. And I hope that even if it's something that you didn't come up with today and you don't have it today, I'm giving everybody my email address. It's, and I'll put it into the chat. I hope that you'll email me throughout these 90 days and say, oh, by the way, can you report on this as well? Can you report on this? Can you do something about this? Because that's the only way I can get better and my organization can get better, is by hearing your feedback. So thank you very much.
Yep. And Commissioner Reesley, just one moment. Dave, there's some questions in the comments, and I would encourage, those of you that are not on the commission that have questions, I would ask you to take David up on his request. And I would also encourage us to, as we move forward with that, looking at those questions and being constructive and thinking about how we're going to move forward. I know there's some community members, I'm sure, that have some pretty significant questions, may have some pretty significant emotion that is also attached to it, probably in best interest of seeing that progress and for the children. So I just ask, though, that as we do this, we continue with that collaborative approach. We can still hold people accountable. We can still hold ourselves accountable by being direct, but let's also remind ourselves that the only way we're going to move forward is to remind ourselves of where we were at and look to see where we're going, and then move the system, move our activities in that direction. So Commissioner Reesley, I see your hand up. Looks like you're on mute.
See, there you go.
There
Sorry.
we go.
Put the hand down, but not the mute. I just have a few questions. Lisa Reesley, for the record. I'm curious, what is your census today?
I believe it's 42.
Okay. So I think last time we met, you said you were averaging 52. So you're down a little bit from there. So, okay. The other question that I have is, it's not really so much of a question as it is just a statement. I think the data that you present is very helpful, and perhaps next time you might be willing to provide that data in writing so that we can view it. But I want to just sort of add a level of caution or inquiry to just broad percentages. And so while saying we've had a 53% reduction in physical restraints is a helpful tidbit of information, the numerators and the denominators in that number really matter. So are we talking about starting off at 500 restraints a month and we decreased from 53% from there? Like what are we really talking about? A 53% decrease in what to what? So I think having access to this specificity around the data and the time periods is probably equally beneficial to understanding what that number really looks like.
Yeah,
okay.
And I also am trying to understand. I'm going to kind of rattle these off, and then I'll let you address them collectively rather than one at a time. I'm also trying to understand, we sort of started this presentation hearing about your organizational overhaul, if you will. Like, this is our new structure, these are our new leaders, all of that stuff. Which, is a very common response perhaps when things go awry. We will just rearrange chairs and we will implement new programs and all will be much better. So I'm curious about, I know you mentioned that Matt and Daniel were no longer with the organization, but I'm not really sure if you said they were no longer with the organization. I mean, when I look at your website, I still see them up there, and I'm trying to understand, really what their roles are in the organization and what the changes are that have been made. It seems like Becky is new to your team, but other than Becky, it seems like we saw the two of you
previously. And so I'm just trying to really understand who is the organization at this point. So those are my statements and questions all rolled into one.
Thank you, Lisa. And yeah, so I'll go on the first one first. Absolutely. You know, I guess we're getting into the hang of this, you know, this commission's meeting. And we're under the understanding that for the next year or two, we're going to be doing every 90 days an update. And so I apologize for not sending, you know, some of the data beforehand so that you could have a chance to, you know, digest that and see where it's coming from. You know, we made sure to double check and triple check our numbers to make sure that we're 100% on this, but having the information about the numerators and the denominators obviously is big, and it helps frame the data as well. You know, and so, you know, I hear you, and going forward, we will have that. As it pertains to Matt and Daniel, they are no longer part of the day-to-day. So let me give you a little more background to that. You know, myself and Jacob Stern have years of experience operating 5-star facilities, behavioral facilities, you know, various kinds of facilities, but really top-notch service and top-notch care, literally 5-star facilities. When we first came into this system, we were, you know, we were new to Nevada. We realized, you know, we can work together. We thought we can work together more with the old, you know, ownership to and then build off that. We saw right away that there were improvements that we want to make, and that these facilities would look like our other facilities, you know, across the U.S. that are top notch. But you know, with time, we you know, as we were seeing, obviously you see that there's, you know, improvements that were made, but we needed faster growth, faster movement, and real organizational change. And that's when it was decided recently, not recent, but it's been in the works for a while, to remove them from the day-to-day organization. As of January 1st, they are no longer part of the managing operation. And I apologize about the website. We haven't been able to update that as fast as we've been working on some of the other changes that have been going on over here. I assure you that Becky Homer is not the only change that we've made and we've been making, and I can follow up with the commission on the specifics of that. This, you know, I can talk to the fact that, you know, we've been doing this for a long time. Specifically, my partner Jacob Stern, who, you know, has been doing this for 25 years with top-notch facilities. He's down with me in Nevada, making sure that this looks like some of his, you know, some of his facilities, and that important that the staff that we take are the best, you know, best in the business. And I can give you more information to that as well, if that's helpful, to see what that
I think that would be really helpful for us. I mean, what you're going to sense coming from us over and over and over again is the theme of expertise in children's mental and behavioral health systems, facilities, care. Like, that's what we're looking for. And so when we, you know, when you tell us about the who's doing what and what roles are being filled within the organization, part of what you probably want to share with us is the bios for all of those individuals and what expertise in children's mental health specifically that they bring to the role and to the table. Because you can probably guess, based upon our questions today and based upon our questions at our last meeting, that ultimately where our concern lies is that there is an absence of expertise in children's mental health that is apparent and evident based upon the clinical services that are being offered at the facility. And so to the degree that you can continue to share with us how you're addressing that issue, you're going to find that's probably the most important issue to us. And I sort of will say it again. I know I said it at the last meeting, that you're not going to find a group of people who are more committed basically to building mental and behavioral health programs in Nevada. Like, we need service array here worse than any state in the nation, as you've pointed out. However, I don't think any of us are ever going to make a commitment to accepting poor service quality just for the mere existence of the service itself. So at the end of the day, that's what we're going to say to you over and over and over again. Quality, quality, quality. What expertise do you have in running these programs? Who's working for you who has expertise in running these programs? And so with that said, I know there are other commissioners who have questions, but I just, again, want to reiterate that that is what is most meaningful to us is, yes, we want you to exist. We want you to be providing quality services to children and families. That's most important.
And if I could just speak to that, I myself, if I'm a parent and I'm, very part of my community, if somebody said they're going to open up services in my community that are going to be subpar or just not top of the line, I'd rather send them out of state. I'm with you 100%. And I'm going to get you those deliverables, Commissioner Durette and all of the commissioners. I'm going to send you the bios. I think to the point is, and this is, obviously we've been talking, specifics, right? A lot of the specifics, but there's a much more overarching vision that is coming from all of this, right? Why are all the commissioners, asking so many questions? Because they're concerned that is this top-notch facility? Are you providing, and where's the bios to back that up, to show you that these are people that not only can run a good program, but could turn around a program that has struggled in the past. And I will send you those bios. You'll get them in your inbox. If there's a way to circulate, just send them to me so you don't have to, you send me the emails of the commissioners. I will send you the specific bios, the specific facilities in children's mental health that our staff, new staff, that we brought in, are specific to this, and therefore you could see our vision the way we see our vision. And I appreciate you pointing out, basically what I didn't realize, coming in here, is that this has always been an issue, right? I'm coming into the market, we saw, yes, there are changes that need to be made, but no, there's always been a perception that this isn't top notch. This isn't where it needs to be. And so I guess maybe it took me a little bit more time than necessary. And it's thankfully we've been able to do it now and make that change. But I assure you that when you see the follow-up email, I'm not talking about in 90 days, I'm talking about in the next few days, of those people, and you'll see our direction, you're going to be reassured and where we're heading with children's mental health, and specifically this facility.
And David, for the record, this is Chair Schrag. David, I appreciate that, because as we move forward, as I shared, we want to make sure that we're getting that quality service in our state, and that you or any facility should be prepared to have those questions. And I appreciate your willingness to have that immediate dialogue that's going to be helpful for us. And we as the commission will continue to have these discussions about what is taking place, where things are going. We're going to continue to have questions to ensure that we, move the needle in the right direction. So with that, Commissioner Ficalora, I know that your hand is up.
Thank you,
Chairman, I
Ficalora,
would just,
for the record.
I would,
kind of piggybacking off of the comments from Commissioner Durette and Commissioner Ruiz about master's level clinicians and the varying level of expertise amongst those licensed professionals. Can you speak a little bit about, you might not have the numbers in front of you, but the number of master's level staff that you have, the licensure, are they interns, or are they fully licensed? And where in the clinical flow, how often are the residents meeting with master's level clinicians for services?
I think that's a Becky question.
Thank you, Becky Homer, for the record, NGU. I can say that at this moment, I don't have the numbers in front of me, but I will say that most of our clinical staff are licensed. I do know we have one intern at the moment. The rest are licensed in terms of our therapists. And then I'm also master's level, and we have a few other staff that aren't on the clinical team specifically, but do have master's level education in a specific realm. However, we're definitely moving towards additional and more robust training, not only for our clinical staff to be more specific to the population that we serve, because I do agree, I do think that we need to do better at better identifying the diagnoses that our kids come in with, but also making sure that even someone that's not master's level understands, some of the symptomology, some of the triggers that can come along with specific diagnoses. That's definitely something I'm taking very copious notes over here, making sure that I can, add this to our 90-day plan. So I appreciate any feedback and suggestion that we can get from the commission to make our facility better.
And if I could just jump in really quick, Mike Spindler, our chief clinical coordinator is also a licensed master level professional. And relative to the question about the folks who have been put in leadership positions and their experience in children's mental health, as Becky mentioned at the outset of the meeting, she has 20 plus years of experience working in children's mental health. I have worked in children's mental health in excess of 40 years. I am an LCSW and was working for many, many years, culminating as Chief Operating Officer in one of the largest children's mental health organizations in the country.
And yeah, and if maybe just one more thing, obviously these are, answers that we can get to you. Just maybe just a suggestion, potentially for the next meeting, if we can, we'll provide you some of the data beforehand so that we can get that to you, and maybe, any specific, obviously we'll be able to address them in the next meeting. But if you want, during the course of the next 90 days for us to address other issues, feel free, please, to shoot me an email. Hey, David, I would like you to address this even before next meeting. Can you send me some information on this? And the thing, obviously, the number one thing for me is to be transparent and open with you guys, because we need the whole community over here. For this to succeed, I need to be open with you and transparent about who my people are and how much experience they have in children's mental health, from the top of my program all the way down to, like you discussed, the behavioral health techs, what's going on over there. And then, administratively, clinically, how are we doing this so that it's abundantly clear. That's the goal, is that you should know as much information as you'd like about our facility. I'd really love to tour some of you in the next 90 days, be out at the facility myself, so we could speak to some of the staff directly and ask them, what they've learned in their training, and how prepared they are. And these are things that I do, and I would love to open that up and keep a really transparent relationship, specifically with this group that is looking for the best of the kids. That's the bottom line.
And David, I appreciate that. And I recognize that some of the questions we will and will ask today and in the future, you may not have all the answers. And please understand, it's not a gotcha session, as we talked about briefly on the phone before, and we talked about in the last meeting. If there's a difficult question that data needs to be provided for to reinforce some of that, please understand from my perspective as the chair, and I believe that the sentiment will be shared with the rest of the commissioners, we want to make sure we get these things on the record, and that if it's something that you have to have legitimate research for that isn't immediately apparent, then we're going to give you that opportunity to get it. So, there are going to be a lot of things that we will have an expectation that you will know and be able to, cite kind of verbatim or very close to it. Those things on the record, so we hold each other accountable as we move forward. One of the quick questions I have, and Commissioner Ficalora, I don't know if you still have a question. Okay, I just wanted to make sure. And Dr. Durette, I'll get to you here in just a moment. But David, what is the ratio of staff to clients at this time, if you have that available?
Yeah, I have that. As of today, we are doing our direct care level staff is 3-to-1. So 42 kids on campus. We've got 14 staff out today. That is, obviously some days actually we'll overstaff it. If we feel like, hey, some of the kids need a 1-to-1. Obviously, it's based on acuity. It's not just, hey, 3-to-1. No, today the campus is a little bit more. It has to do a lot with some of the data metrics that I get every single day. We look at trends and things like that. So we're like, okay, let's throw on a few more staff today. Yeah, and I'm happy, by the way, to share stats and like if we have a regular reporting session, we could even start off the meeting with, okay, and here are your requested reportables, and be abundantly clear about that.
And that may be something that we do, is there will be some standing items that we will ask on a quarterly basis, and the commissioners and I will discuss that in our closed session about maybe how we can work to structure that, and of course then bring it to the public session so everybody is aware of kind of how that will go. Of course, we want to have transparency as well and ensure that for our own accountability. If you know it, and maybe it's going to be shared in the bios coming up. The only other question, and Dr. Durette, I'll pass it over to you, is when we look at those master's degree level staffing that you have, what are those degrees in? Is it is it family therapy? Is it general psychology, social work? Like what are we looking at in terms of those individuals that we have? Is it clinical focused? Is it research focused? Is it again general? And then what is the licensing that then would go along with that? You may not have that immediately available, but I know that's something we would all want to know. Again, going towards Commissioner Reesley's question on the expertise and the quality of care. So
absolutely.
If you have that, great.
Yeah.
If
no,
not, just be prepared for.
I want to give you the. Absolutely. I want to give you the actual bios instead of listing them off.
Perfect.
So we'll follow up with that. And I just want to say that I appreciate the passion for this, and to know that you're all as passionate as I am about specific to our population, and not just clinical, just X amount of clinical hours specific to helping these kids, and also, by the way, seeing that translate into reduction in length of stay. we have to, we can't just plan something. We actually have to see it play out, and that's been my big focus also, not just getting clinicians on board. I don't care so much for clinicians that are going to be remote, right? They have to be able to come on campus. Our campus is very remote. I don't know, I really hope some of you take me up on the offer of giving you a personal tour, together with my clinical staff, and you can see the residential, the clinical, medical, everything. But it is a drive from Vegas, and it is out there. But that's part of, when we were talking about potentially relocating or being closer because of staffing needs. One of the bigger draws out there is the fact that it's the environment is therapeutic, to be far away from and being in sort of in an open campus, 25 acres. There's a lot of space. The kids don't feel as restricted. Not to say that we're not looking at, down the road, having, obviously we've got our hands full right now, but having a location closer to Vegas where they could, get more integrated back into school and their families, and more being able to step them down faster. But there is something about that campus being out there, and the therapeutic nature of it being out there, as hard as it is to get staff to come out there. We're not gonna compromise on that. If you know what I'm saying. We're not going to say, okay, just because it's hard to get quality clinicians out there, we're not going to do that, or we're going to do it remote. It's not the same. So we understand that, and that's been a very, very big focus for me, is getting, in the last few months, getting people out there on campus, people who have experience in specifically in children's mental health, and understanding how that it pertains to residential treatment.
Okay. Dr. Durette, you have a question?
Yes. I have a large question, but a couple of branches, and it really all ties to this concern that there's a lack of expertise in children's mental health and development at the helm. You just made a comment in your conversation about staffing that kids are on a one-to-one level of observation. And in best practice, if a child rises to a one-to-one level of observation, that constitutes an acute level of care. And children should not be maintained at a one-to-one level of observation in a residential treatment setting. So that's concerning. And furthermore, I was looking at some of the commentary in the chat, and a question was raised about the frequency with which kids can call home. The answer was once a week it is scheduled. And again, that's really antithetical to what's best practice in children's mental health care. By not having the frequent contact with their family or family systems, it's perpetuating the discordant attachment that they're having with their primary caregiver. And it is only potentially going to exacerbate and make worse their ability to transition back. And so that, to me, is a glaring reflection that the expertise in children's mental health is not there. And so here's my question. We've talked about the medical system, you've talked about nursing. One thing I've never heard yet is talking about child psychiatry. I have not heard about the role of psychiatry and nursing in the whole seclusion and restraint process, nor have we heard anything about the clinical expertise in the process of an assessment, the admissions process, the frequency with which physicians and psychotherapists are involved in treatment. And that's really critical for the entire function of a residential treatment center. It's in the best interest of children. So I'm hoping you can comment on all of that wrapped into one large statement, please.
So I'll let Michael start, and then I'll take it from there because it was kind of
David, I was going to let you handle that, but
sure.
I guess I don't have that up. No, I'm teasing. Can you forgive me, but the first part of your question was having to do with the expertise of the staff on campus?
The theme of all of it is about expertise. And I believe it was David that said kids end up on a one-to-one level of observation. And if you need a one-to-one level of observation, that's an acute level of care, not residential anymore.
Well, I would suggest to you that the children we get in care, probably 98, maybe 99% of the children come to us from one of the acute care hospital settings. It is not unusual for children in our residential treatment center, children in residential treatment in general. I mean, it's essentially the same population that the acute care hospitals were serving, that periodically we do experience a child who decompensates, part of their psychopathology. And in those instances, one-to-one care may be absolutely indicated in order to help that youngster reconstitute and give up the one-to-one and rejoin the general population, all the activities, etc. It is always our preference, when possible, to avoid an acute hospitalization, work with the child on campus, and support them in reconstituting emotionally. So one-to-one care, as far as in my view, is both not particularly unusual and frequently warranted if we're experiencing a youngster in crisis. So that is my point of view as far as.
As a follow-up to that, Michael, I heard you say removed from the milieu and brought back. So if a child's on a one-to-one level of observation, furthermore, they're removed from the milieu.
I'm sorry, say that again.
If a child or an adolescent is placed on a one-to-one level of observation, are they then removed from the milieu?
Oh, no, not at all. Not at all.
You had mentioned that they're taken away or are removed. That's why I'm asking.
No, I did not. I'm not suggesting that at all. I'm suggesting that if a child requires an adult support for a period of time in the program, that's fine. We see that all the time on a pretty regular basis. I'm not suggesting at all that child is removed from the campus or removed from the program and put in our sanctuary unit, if that's what you're suggesting, or if that's what you understand me saying. I'm not suggesting that. Having said that, it may be necessary initially if a child is experiencing real emotional dysregulation to spend a brief period of time in the sanctuary unit to kind of get themselves together and then return to the program on a one-to-one with a one-to-one counselor for a period of time, enhanced and increased psychotherapy by their therapist and whatever else is necessary to help that child reconstitute.
What's the average length of time that somebody goes on to a one-to-one?
Becky, do you have a sense about that?
I do not have numbers for that. However, typically with our one-to-ones, just to maybe a little bit of a clarification is that, our one-to-ones are centered around behavioral modification and observation rather than, suicidal ideation, which is what typically happens within an acute hospital. So I just want to make sure that that clarification is noted.
I'm not sure that clarification is necessary. It's more of the acuity that puts somebody on a one-to-one. And not to call anybody out, but I know that there are other directors of inpatient facilities or former directors of inpatient facilities on this call who would also agree that that seems to be different than the typical standard of practice. Likewise with the phone calls only once a week. So really what I want to come back to is the expertise and talk to us about medical oversight and psychiatric oversight.
And I appreciate the question and not just the question, the direction, right? The questioning, holding everybody accountable. This is, I think, going back to the question that Lisa suggested before, is that what is this team? Who are you? What is your team? Give us an idea of what where the experience is in children's mental health, mental health. And I would just, to that, I would say, can we give you the bios, give you that information, and if you're still not satisfied, obviously, we can take it from there. Would that be satisfactory?
Well, yes, but I would hope that you could talk to us about your medical directorship and what the psychiatric oversight of these highly vulnerable youth are.
Yeah, and we do have a psychiatrist oversight. We have many levels of oversight at the facility. We've got nurse practitioners, and we can report to that. I will follow you up on that.
I would just add, David, that in terms of the level of expertise having to do with children's mental health, that on the resident or the residential side of the program, our managers and leadership have been in the business of children's mental health a significant period of time. You will see that when you get the bios. On the administrative side, including Becky, myself, and a number of other administrative staff, they have been in the field of children's mental health for a significant period of time. And our clinical people, including our chief clinical coordinator, who has a PhD, has been in the field and licensed, and she's a licensed marriage and family therapist, has in excess of 25 years of experience. But you will get, when you see the CVs, you'll have an opportunity to look at that quite specifically for each individual.
Dr. Durette, do you need any further clarification, or shall we offer the opportunity to collect the data and provide it to us?
Yes, and in that data, I would strongly recommend that you share with us a plan of action for at what point is a psychiatric evaluation done, how frequently follow-ups are done, if it is a nurse practitioner, who the physician is overseeing them, what type of expertise or training do they have specific to children's mental health, what the pharmaceutical oversight is around polypharmacy, because that has been a concern by us at the commission when we reviewed seclusions and restraints, and we have observed inappropriate chemical restraints being used. And so, quite frankly, I have a lot of safety concerns for the well-being of the children.
Yeah, and David, as discussed, I want to be fair to, again, there are some things we will hope that as you move forward with these transitions, that'll be a little, there will be the opportunity to have a little more immediacy with the response, and in the future, that some of these things you will get I think you're getting a sense of the issues that we have and what we will expect to have known in the future. And so with that, just I would be prepared for that. And then also, if there are things that we need to, I want to make sure that we give you the opportunity to collect. I don't want it to be a gotcha moment. It may be a little uncomfortable at times, but I think for all of us, it's necessary. It's a necessary uncomfort, if you will. It's unfortunate that some of these questions are having to be asked, and we'll continue to be in a direct nature, but we also want to have a little compassion too, as you wrap your arms and take on what I think, as you indicated earlier, is kind of a Herculean effort when there's been such a degradation in quality of care, service provision, services being provided, that, the whole culture change, the shift, the training, personnel, staffing, it's almost like starting a new business from scratch, if you will, starting a new organization. And so, again, we'll be a resource.
Chairman, it's actually more difficult. It's easier to start from scratch than to turn around an organization, actually.
Yeah. So
But I am certain that once we will give you that information, it will put you at ease in terms of the experience and the direction. And by the way, organizational change is not comfortable. I've had many more uncomfortable meetings than this in the last couple of quarters to be able to accomplish what I have, and the numbers won't lie. You'll see, the data that's coming out of this, that the discomfort, these types of conversations, is what channels the real change that this state needs.
Are there any other commissioners with question or comment who would like an opportunity at this time?
Commissioner Giron, for the record. David, I'm a pediatric psychologist and worked inpatient and outpatient for the last 30 years with children. And I know that this state really needs a lot of help. And I wish you the best in developing your program there and all the resources you need. Because yes, Commissioner Durette's comment on pediatrics and child sensitivity, understanding, development, they're much more than just the diagnosis, and they're just much more getting them back, that connection with family, that connection with their therapist, before they leave and when they come back, everything you're doing is one piece of the cog. And yes, our state needs really a lot of support and help there. I'm a rare breed here. I don't meet too many people in my ilk. So when I see a place trying to help children, I'm cautiously optimistic that this will work, and hopefully, you will get it to work. And what you're saying, your candidness, you're coming into the commission with this effort to show us what you're doing, I think is just terrific. So please keep it up. Don't stand for second best. Find your resources. Yes, make sure that your therapists have backgrounds in child development, or bring that on as a regular in service to your staff. Yeah, you can work it with kids, but then you never work with kids. You could be helping children, but you never really are there. And a psychiatric nurse is trained in pediatrics is very important. Yeah, pediatric psychiatrist is very important. And they're all part of it. So good luck.
Right.
And thank you. I'll look forward to the next report.
Thank you so much, and I appreciate that. Yes, there's very few. We've looked at every child psychiatrist in the state, and it's unbelievable how few you could have in such a large population. It doesn't. I don't think there's anything like it. But that, there are a lot of challenges. I have to say that this is the hardest thing I've ever done in my life, and I've done some hard things, but I am very, very hopeful. I really see so many people who care so much about their community, and it's people like Kyle Dunlap and in my organization, and Becky Homer, and even the rest of you working 7 days a week to do whatever is necessary because they're so passionate about it. And it's, some days it's like, how are we going to do this? And then I see the people step up, and I am really, really encouraged today. I'm happy that I'm getting the hard questions directed to me. And I just commend the bravery of everybody who's going to continue to ask the hard questions, because that's the only way we're not going to settle for number two. We will not rest until we are the best that we can, and then we're going to continue from there. So thank you so much, and I'll turn it over to Kyle.
Yes, thank you. This is Kyle Dunlap with Epic Behavioral. For the record, very briefly, know that we very appreciative, I will say, of the time allotted to us and us, sharing a lot of insight to our program and, of course, our commitment to improving. But first and foremost, I want to mention that I'm an advocate in this space. Of course, the enhancement of services, better navigation of services throughout the state, the reduction of stigma surrounding mental health, and of course, for evidence-based treatment in our state. As David alluded to, Nevada currently ranks 51st in the nation. When you think about that stat, there aren't even 51 states. So the rankings do factor in Washington, D.C. We're dead last. You cannot get any lower or higher, however way you look at that statistic. So we collectively as a community have a lot of work to do. I also want to mention that I serve as a president of NAMI Southern Nevada, which is the National Alliance on Mental Illness. I've been aligned with that organization for over half a decade. Been attached to NAMI in some fashion for close to 2.5 decades. And truly, I would not align with nor represent an organization providing subpar services. So, I want to draw that connection, to hopefully instill some confidence in the commission and the greater community that we have passionate, not only educated, clinically steeped individuals supporting our organization and the youth that we serve, but those that have personal experience in the space. I'm also the older brother to a family member who is a successful product of a residential treatment facility following a suicide attempt that he made in high school. So, I personally understand the value and relevance of an RTC level of care in the greater continuum of care, behavioral health model. So I've committed my life to ensuring strong, lasting outcomes in this space specifically. So, just wanted to make that comment. Wanted to, share my appreciation for all of this, incredible feedback that we're receiving, but also to highlight our commitment to ensuring we get off that 51st spot in these national rankings. But the only way to do that is to collaborate, to work with child and adolescent psychologists, psychiatrists, master's level clinicians, and ensure that we are providing the best care absolutely possible. So certainly look forward to updates, specific to each and every question that's been presented during this meeting. And of course, collaborating with more of you, and also, like David mentioned, I not only challenge but welcome and encourage every member of the commission to tour our facility up in Nye County. We're based in a rural county. We provide services, to youth from every corner of our state. But the fact that we are located in a rural area of our state, also highlights the, not only the challenges that we face, in terms of logistics and staffing, but we're providing a service in an area that does not have any other robust mental health services at this level of care. So, just to empower the community to get behind that notion in and of itself, I'd like to love to showcase what we have going on up there. So thank you again.
Thank you, Kyle. And I think it probably goes without saying that at some point we will be taking you up on that offer. Some of us will try to find our way over there, whether we caravan or we come out as individuals. That we'll take a look and see. I think it'll be good for us to get some eyes on out there as well. So. With that being said, I know this is for a possible action. Before I move on, are there any other questions from any of the commissioners at this time? All right. I know it's set for possible action. I don't know if there's anything necessarily to approve here, and I don't know if our DAG or Katie can weigh in if we need to. I understand, I believe we're going to be setting and having an expectation that Epic NGU will be here at least on a quarterly basis. Katie, is there anything that we need to do aside from just, we'll just have it as a set agenda item, or is there anything that that we need to move forward? Because it's really more of an informational moment right now.
I don't believe, this is Katie Martin-Waldman from DCFS Professional Support. I don't believe there is anything else. I will ask Jennifer Spencer to confirm.
This is Jennifer Spencer with the Attorney General's office. Yes, that's correct. And even though it says for possible action, it's not required that you take an action today if you choose not to.
All right. Yeah, I don't think there's, I appreciate it. Thank you both. I don't see a specific action. The only thing, again, David, for you and your team, please just be prepared for, to come. We'll set a quarterly agenda for the rest of this year, for y'all to come and provide some feedback. And we look forward to, in the interim as well, as the commission comes forward with additional questions, we will funnel those through either myself. It may come directly from one of the commissioners, or it'll likely come through our administrative team. So for our tracking purposes, to make sure that we get everything we need taken care of. So just be prepared for that, and we look forward. And I would also encourage to keep that dialogue going and to help with kind of working through some of those that timing of response will be important, and I'm glad to hear that it's not going to be a quarterly report, that some of the things we've talked about today that you'll be pushing forward in relatively short order.
Yeah, within the next week, and I appreciate that, Commissioner Schrag. We will be sending over information. So I guess through Catherine Martin-Waldman, we'll put together that stuff, and she can get that out to the commissioner as through that. And please reach out if there's anything that I could provide, in the interim basis, even if it's something that comes up. I want that to be the type of relationship that we have, that you don't have to wait 90 days for anything that you want. Shoot me an email. You guys all have it now. And I will get back to you usually within 24 hours.
Yeah, and I would just add one additional caveat, David, that I'm sure that you will have, there's questions in the chat. I'm sure you're going to have some questions from some other community members. What I would ask is that as you get asked those questions, please include that with any correspondence back to Katie. That way we can be aware of it. We have a really strong and lively community that is going to have some questions. I just want to make sure that we're tracking. That way we are not double asking those questions of you. I want to streamline that process to the degree possible. So as those are funneled to you, if you have answers, please include that to Katie, so we can make sure as a commission that everybody's moving in the same direction. So
absolutely, I will do that.
Excellent.
Just one more thing, if possible. Please. Obviously, I do think that some of you maybe don't know yet the full picture, and you'll get a lot of that soon. But once you do understand the picture of who we are and what we're looking to do here, I really would ask everybody here that to join us and help us, because it can't be that the only issue is that we're just not, providing a service at the level that you need. It has to be a system of care, and it has to be a Nevada specific issue. And the only way we're going to do this is collaboration, which means there's going to be work that's going to be needed from the community as well. So as much as I'm reaching out to you guys for help to do this together. I will first show you our, what we brought to the table, who we are, what we're about, what our vision is. But once we have that, I need the help of everybody here, so that this community decides together what the mental health future is for Nevada, not maybe one or two people, siloed somewhere deciding whether they want this level of care or they don't want this level of care. This should be something that the entire community has a voice in and really gets to push together. That's it. Thank you.
All right. With that, we will close out agenda item number 4 for today, and we'll move on to agenda item number 5. It says for possible action, but as I understand, due to some timing, it's actually a item for discussion and not necessarily for a possible action yet. And so with that is in one of our recent, if it's to look at drafting a letter of support for the regional policy boards. I know in one of our last meetings we discussed that, and so what I'd like to do is bring it up for the commissioners and maybe perhaps do just an ad hoc subcommittee so we can work on drafting something up, get that put together. And so I'd like to open it up to the commissioners for discussion, and just a reminder that, we want to look at, we have our annual letter. This is not going to, I want to clarify, this won't take place of our annual letter. That still, there's a statutory requirement that has a multitude of elements that have to go into that. This is a standalone, much like Dr. Durette, the direction we had last year in helping to look at the issue of parity pay and pay for our staff to help with that. So this is going to be akin to that, where we're looking to take and provide a very focused letter of support for our legislators and the governor to see, as the commission, we are supporting them. And they're going to have a lot to read already with the BDRs and other aspects, but so it's to that direction that we're heading. So commissioners, any thoughts, anything we'd like to see so we can then put together something and move forward?
This is Jennifer Spencer with the Attorney General's Office. Can I please see if there's a clarification of what agenda item we're on right now?
It's agenda item number 5.
Okay, so that would be information only for announcement. So
okay, we can't have a discussion on it?
No, not this time, but that doesn't mean you can't set it for an agenda item for the next meeting.
Okay.
Yes.
Okay.
And the concern that I have is the agenda item that says for information only announcements. It's very vague. And so it really can't, we can't bring up specific topics that have not been noticed yet.
Okay. We will omit then item number 6. Is that correct?
Well, I thought we were on number 5. Is that correct?
Yeah. The one you were mentioning about information only for announcements, that's actually agenda item number 6, at least on my document in front of me.
Oh, okay. The copy I have has those switched.
Okay.
For the one that says for information only discussion and identification of future agenda items, you can certainly talk about future agenda items that you will put on the agenda without taking a vote.
Correct. Yeah, I wasn't going to take a vote. I may have no, we're not going to take a vote on that. It was just to discuss, and then we'll put it on the next, we'll we'll put it on the next agenda.
Okay, thank you.
Yep, no problem. Commissioners, any discussion on this at this time?
Commissioner Durette, I didn't do the electronic hand, couldn't find it fast enough. I think that, you know, we've got the 5 regional boards who all have current BDRs, or maybe they're even moving forward, that are all extraordinarily pertinent to the mental health workforce and the issues that we as a commission have been discussing for years. And so I would just make a suggestion that we would craft a letter that is supporting those 5 specific bills and get that out as soon as possible. So I have a question for our DAG, just from like a procedural thing. With open meeting law, if we were to schedule like a subcommittee meeting, what's the time frame that you'd have to announce it for the meeting? Do you see what I'm saying? Because you have to do the whole posting of agendas.
It would be the same process for, you know, doing that subcommittee notice as you would for any other type of meeting. So it's all contained within the open meeting law requirements. So hopefully that answers your question.
It does. Thanks.
All right. So do we want to make a another question for the DAG, for us to get that put on for the next agenda? So we should just, as Dr. Durette mentioned, just move forward with doing a public announcement so we can get going on that.
So what you would do is you would agendize it for your next meeting so that you can discuss and take action at your next meeting as to, for example, if you're going to develop a subcommittee or what type of, you know, action you're going to take at that point. But for today, it's just placing these topics on the next agenda so that it can be agendized and noticed, and so the public can understand what will be discussed at the next meeting.
Okay. Okay, and I think our next meeting is February 9th on the DPBH side of the house. So that's a pretty quick turnaround. And I think we can, I believe autumn is on. We'll make sure that we get that put on so we can have that as an agenda item. All right. I don't think there's any other action we need to take or at this time. Correct. Katie or DAG?
For these agenda items that we have, they're information only. So I think the next one will be the public comment.
Yep. Okay. I just want to make sure, I think we've already discussed future agenda items. So yeah, we'll move on to public comment then. Agenda item on mine, it's showing number 8. No action may be taken upon matter raised during this devoted time to public comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action can be taken. As a reminder, please state your name and if you're representing an organization, and public comment is limited to 2 minutes. Please limit your comment to that time frame. Do we have anybody for public comment at this time? Carissa?
Good morning, Commissioners. My name is Carissa Toshiro. I'm an attorney with Nevada Disability Advocacy and Law Center, the state's protection and advocacy agency. Under our Federal Access Authority, we've been monitoring Never Give Up since May 2022, and we spoke at the October 20th Commission meeting about our concerns about the safety and treatment of youth at the facility. Since then, we've continued our in-person monitoring. Youth are telling us that dangerous, painful restraints are still occurring at NGU. One child told us he was slammed against a wall. Another said she was choked. Multiple youth said that staff pull the hems of their shirts over their faces to prevent spitting during restraints. During our December 2nd visit, we observed a youth being restrained when there was no immediate safety threat. And that's also reflected in the incident reports, which show that youth are being restrained for reasons other than safety, like refusing to follow directions or becoming emotional. We understand that seclusion in the sanctuary unit is still being used for punitive purposes. During our monitoring, one boy reported he was in sanctuary for 6 days after being caught with contraband. We met with the girl who was in sanctuary for 2 days as punishment for attempting to elope. Multiple incident reports corroborate that sanctuary is used for extended periods of time and for punitive purposes. For example, a December 2nd report that states that youth remained in sanctuary for the rest of the day, and a December 4th report in which staff writes about a child. I told him I was not going to go back and forth, and he needed to return to his unit or spend some time in sanctuary. We're still getting allegations of abuse and neglect, about inappropriate chemical restraint. We're still concerned about facility conditions, efficacy of treatment. I personally observed staff tell a girl who tearfully said she was suicidal that they were too busy to help her. A family told us that their child got more frequent therapy when he was outpatient than what he gets at NGU. There's still concerns about psychiatric oversight, clinical expertise, the inclusion of families and treatment team meetings, about discharge planning. Sadly, some of our clients have gone home with no services and have cycled back into acute care or the juvenile justice system. We appreciate the Commission's inquiry into this important issue. We'll continue to monitor the facility, and we reiterate our offer to provide more information about our monitoring or to present at a future Commission meeting if that would be helpful to your work. Thank you.
Thank you very much. Char, I see that you were the next one up, please.
Thank you, Commissioner Schrag. My name is Char Frost. For the record, I'm the Statewide Family Network Director for Nevada PEP. And I wanted to first say that I truly appreciate all of the questions that the commissioners have posed today regarding the operations of Never Give Up. Nevada PEP, we work directly with families, providing family-to-family peer support every day. And I just want to let everybody know those clinical pieces are important to families who may not be able or do not have the education to ask those questions, obviously. However, when we make a difficult decision to send our child to any kind of hospitalization, but specifically residential treatment, we need to be assured that our children are as safe there as they are at home, and that they're not going to come back to us worse than they were when they began. They need to receive treatment, evidence-based, evidence-informed treatments, and they need to be provided with opportunities to talk to their families as often as they wish, just as they would have been able to do if they were diagnosed with cancer and were at a physical hospitalization. Treating children with mental health differently than treating children with physical health continues to persist in, contributing to stigma that is still related to mental health, and stigmatized language that is used that leads to bias and prejudice amongst the general public as well as service providers. Thank you.
Thank you, Char. Commissioner Reesley, I saw your hand up. Did you have a public comment as well?
I just had a question, and it was for the speaker before Char. I believe it might have been Kaleah Cage with Nevada Disability Advocacy and Law Center. Hi. So, hey, I just am curious. You read out sort of a laundry list of findings for the last month. All of those are reported to HCQC, correct?
We filed a complaint in June. Since then, we've been engaging in monitoring and are in the process of compiling our findings from that monitoring.
So is HCQC in possession of the reports that you described in terms of incidences that were told to you for the month of December, or are they not aware of those yet?
They're not aware of those yet, but will be.
Okay, and when do you anticipate those will be sent to them?
Likely by the end of, probably by the end of next week.
I'm just a little concerned about the delay in reporting of the incidences to HCQC. Are those incidences reported anywhere else? So like, for example, when you say we have evidence of abuse and neglect, I'm assuming there were reports that were made of those incidences to the DCFS Child Abuse and Neglect Hotline, for example. are those reported?
The challenge with reporting to DCFS is that we have been told that if we do not have a birth date and full name of the child's parents, that they cannot take a report on those incidents.
Okay, so I personally have a very big concern about the delay in reporting of the incidences and the incidences not being reported. I mean, you know, there's a statutory requirement for reports of abuse and neglect as a mandated reporter. So I don't know if the DAG is still on with us, but I think it's worth consideration of where this public information goes from here and how quickly it goes from here. Just in terms of what you read into the record. I understand that you're working on a report that will go to them, but I think it's something that needs to be reported more quickly than perhaps it has been. Do we have a DAG on the line at all still, or they may have cut off?
This is Jennifer Spencer from the AG's office. Yes, of course. These reports should be made immediately to child welfare as well as to DPPH. So I'm not sure if you had any additional questions for me, but I'm certainly here to help with any questions you may have, and hopefully I can provide an answer.
Thank you, Jennifer. Let's talk after this call about the challenges of reporting incidents where we don't have the information that we've been told we need, like date of birth, full name.
Certainly.
Okay.
Yeah, I think it's good that we get clarification on that. Not just there, but you know, for this particular incident, but anything else moving forward, it'd be good in those other instances, and it might be something we can discuss potentially putting on the agenda so we can get some clarification to this group. Yep. All right. Dr. Durette, do you have a live hand public comment?
Yes, but then like the chat was covering up the thing. Commissioner Easley, you have an extensive background in the child abuse and neglect world. By the statutes about reporting, I was not, as a mandated reporter, aware that a full date of birth is a requirement. Do you know whether or not that's accurate?
It's been, you know, a few years since my child welfare days, but no, it should not be. I mean, we should be able to take those reports and do the necessary investigation with minimal information that is provided. So I'm concerned if they're rising to the level of what we heard in the description that they would not necessarily have been reported or accepted for review. So that's issue number one. The second issue is, again, the licensing of the facility and how those should be reported super timely to the licensing bureau, which would be HCQC. So I just want to make sure that we tie a bow on that, just because it's necessary. Like these are urgent situations that require immediate review. So again, unless the statutes have changed significantly, I would say these are worthy of reports. And our obligation is always to make the report. It's DCFS's obligation to determine whether or not it rises to the statutory level of abuse and neglect. So we'll let them do their job, but based on the information, I don't believe that, rising to the level requires a date of birth.
Yeah, I was going to say my own experience working in child welfare that, I would get reports of just a kid at a location and they may not even have a name. And then through that investigative process, we would be able to determine that as well. So, but yeah, it looks like we've got our DAG Jennifer's going to get with those needed, and then we can provide some clarification at one of our next events, so we can make sure that there's a good, clear understanding. I apologize. Let me see if I can find it. Looks like Amanda, you have a question or a public comment to make.
Hi, this is Amanda Haboush-Deloye, and we also run Prevent Child Abuse Nevada under our center, and I can verify that you do not need the date of birth in order to make a report. You technically don't need anything about the child. It's not very helpful to find the child or to move forward on something, but you can make a report with any amount of investigation that you have. It is just recommended. So that way it makes it easier. And if you know the date of birth for the child and more importantly, their age, it helps to escalate the issue because age is one of the factors. The younger they are, then they have to respond quicker. So that may be the requirement that somebody's thinking of, is that CPS has a mandate to respond quicker if the level rises depending on the age. So I also put in the chat, anybody can reach out to me. We do have a training that we offer on recognizing and reporting child abuse to professionals in the community that is also that can be offered for CEUs. So if anybody needs that, we're more than happy to provide it. Thank you.
All right. Is there anyone else with public comment at this time? All right. Seeing and hearing none, we will close out public comment and we'll move to adjourn the meeting today, and we will move into closed session. We'll give a 5-minute break for everyone that is going to be in closed session. And I believe Katie has sent out a separate link that will connect us. So we'll be closing this down, and I want to appreciate everyone for the discussion, the thoughts, the commitment to our youth in this state, and the willingness of everybody to move forward as a collective collaborative. So please continue to do the things to take care of yourself, to take care of those around you, and move us forward. So thank you very much for your time today, and look forward to seeing you on our next meeting.
Well done, Brandon.